At the outset, let me invite Dr. Janardhanan and Dr. Nimesh Parekh. Thank you both very much for accepting our invite, especially Dr. Janardhanan. It's a very late hour. I think it's about 10:30 in Melbourne, so he has stretched his sleep time today for us, and we are grateful for that. It's really great to have you with us. We've heard you on various forums, and it's been exciting to listen to you in the past, and today we are blessed with the opportunity to listen to you in person. So welcome to our forum.
Thank you.
With the permission of the chair, shall we start the proceedings, Dr. Parekh? Dr. Parekh is with us. Can we unmute Dr. Parekh, please?
Yes, sir.
Yeah, thank you. Dr. Parekh, if it's okay with you, we can start the proceedings for the evening. Dr. Parekh?
Sir, I will call him. Call him.
Yeah.
Hello. Hello. Hi, sir. Will join in within 2 minutes, sir.
Okay. Yeah, good evening, doctor.
Hello.
Yes, can you hear us?
Yes. Okay.
Right. So welcome to our forum, Dr. Parekh. We are happy to have you with us. Dr. Janardhanan is already with us. So with your permission, can we start the proceedings for the evening? Lovely. Great.
Yes. Yes.
So welcome everybody to the new edition of the D.Y. Patil Lecture Series for postgraduate students. And as we promised you in the past, we continue to bring you very, very exciting stuff for all our postgraduates. And dare I say now, it is not just postgraduates, but almost all the faculties as well who started being a part of our lecture series. We are happy to have with us today Dr. Janardhanan. He is an ex-alumni of NIMHANS, and I have interacted with him at various opportunities. So we invited him, and he kindly consented to discourse on this platform, though he is now in Eastern Australia in Melbourne, so it's close to 10:30 in the night. So he has nonetheless agreed to be with us at our designated time. I will leave the job of introducing him in detail to our chair for the evening, Dr. Nimesh Parekh. Dr. Nimesh Parekh is chairing the session today for us. He is a professor and head of department of psychiatry at the NLMMC Medical College at Ahmedabad. He has been the past president of IPS Gujarat State Branch. He has published many articles on mental disorders in various newspapers. He is one of the pioneers of PG training of interns in Gujarat, and he's conducted workshops at ANSIPS in 2017 on the same. He's given various public and international lectures on stress management, defenses, and maturity. He's published various original research papers in different psychiatric journals, and he's an examiner for MD psychiatry at various universities across the Western Zone. I've had the good fortune of engaging with him on some forums where I have been an examiner myself, and it's been a pleasure to always interact with him. And we thank him for having taken the time today to chair this session and be with us today. over to you, Dr. Parekh. I will come back to you right at the end of the program.
Yes. Thank you very much, Dr. Rashmin Bhai. It's very initiative, I think, for the PG students. And today's topic is very much interesting. First, I heard the topic. I feel that it is something which we are not regularly practicing. It is as we know that OCD is a very disabling disorder in the psychiatric field. We know that is most of the psychiatrists find it's very challenging to treat the OCD patients. And as all over the world, we find that at least one half of the patient finds some resistance to the treatment part, and the prognosis is also very much guarded, as we know. So this is very, very fortunate we have with today's topic about modulation, neuromodulation techniques and its scope in OCD treatment. I share the knowledge. I have privilege to introduce our speaker, Dr. Janardhanan C N. He is a consultant psychiatrist at the Goldbeach Valley Health, Shepparton, Australia. He was an additional professor of psychiatry and a Wellcome Trust DBT India Alliance Intermediate Fellow at the Nimans, Bangalore, India. He worked as a consultant at the OCD Clinic and the Weiser Neuromodulation Program at Nimans. Dr. Narayan Swami's area of research interest are obsessive-compulsive and related disorders and non-invasive brain stimulation. His PhD work was on neural and immune predictors of SSRI response in OCD. His research work includes examining biomarkers predicting the medication response, neuroimaging using functional MRI, neuropsychological markers of psychiatric illnesses, EEG research in OCD, and non-invasive brain stimulation using transcranial direct stimulation, cortical stimulation. He is an India site member of OCD Brain Imaging Consortium, Enigma OCD Work Group, India site investigator of multi-country R01 grant on brain-based biosignatures of OCD. Dr. Narayan Swami was a clinical supervisor for inpatient intensive cognitive behavior therapy for refractory OCD, body disorder, and allied conditions. He has over 180 PubMed index publications. He is a recipient of many national and international awards such as Department of Science and Technology, Inspire Faculty Award, Department of Biotechnology Innovative Young Biotechnologist Award, Indian Psychiatric Society Young Psychiatrist Award NSIPS 2014, Society of Biological Psychiatry International Fellowship Award 2011, Samuel Gerson's Award SOBP 2012, Lily Young International Fellowship of International Society of Bipolar Disorder 2012, Asha Award by Indian Association of Biological Psychiatry in 2014 and 19, PPA2 Award NSIPS 2014. He has been mentoring many MD students and research scholars. So he is, I think, a very, very perfect person to talk about neuromodulation for OCD. So I hand over to Dr. Janardhanan Narayan Swami for this well-read person for this topic.
Am I audible?
Yes.
Thank you, Dr. Nimish and Dr. Rashmin. It's a pleasure to be a part of, to deliver this talk in this forum. What I'll be doing is to give some sort of bird's eye view of the various neuromodulatory options that are available in OCD, and take you through the basic premise as to why neuromodulation might be an important area in OCD, and then talk a little bit on non-invasive techniques, followed by the invasive neuromodulatory methods. So I'll share my screen.
We aren't yet able to see the screen.
Okay, is it visible now?
Yes, yes, it is.
Okay, great. All right. So let me begin by stating that I don't have any conflicts of interest for this presentation. I'll be talking about some of the devices. I do not have any financial disclosures, nothing to disclose as a part of the presentation. When we talk about OCD management, we all know that there are two first-line methods to handle OCD. One is the medication, which is SSRI, and the second part is the cognitive behavior therapy. When you look at most of the treatment guidelines, you'll find that both of them find an equal space. In fact, some of the guidelines talk about CBT as a first line and then keep SSRI as as an option when CBT is not feasible. But generally, meta-analysis prove that SSRI and CBT both have equal evidence in the management of OCD. While when someone doesn't respond adequately to the medications, as the first line medications, if there are partial responders, then atypical antipsychotics and glutamatergic medications have some evidence as augmenting methods. However, you have a significant proportion of people who do not respond to SSRIs and the conventional treatment options, and a proportion of individuals enter this category of treatment resistance. And there is a small proportion which does not respond to a large number of treatment options, and you would call them treatment refractory. So technically, when someone fails at least 2 SSRI trials, you would consider treatment resistance. While when there is a failure of multiple evidence-based treatments such as SSRIs, augmenting strategies, cognitive behavior therapy, combination of SSRIs and CBT, so various evidence-based options fail, then the term refractory is used. So the term refractory might be more relevant to the use of some of the invasive neuromodulatory techniques, while the non-invasive techniques could be considered earlier in the hierarchy of treatment options. So why are we discussing neuromodulation in OCD? This is primarily because of a lot of advances that have happened over the past couple of decades in the understanding of the biology of OCD. Now, OCD is one of the psychiatric disorders wherein there is a putative mechanism that has been discussed over the past 2 decades, and mostly this is about circuit-based understanding. So there are some circuits, and these circuits are frontostriatal in their location. So this particular diagram is quite interesting, and it helps us understand these circuits in a easy manner. As you can see, these circuits are called the cortico-striato-thalamo-cortical circuits, indicating that the circuits begin in the cortex, pass through the striatum, certain parts of the striatum, ends in thalamus, and it's relayed back to the cortex. Now, depending upon the cortical regions where these circuits start and the regions within the basal ganglia where the circuit passes, now these circuits have different names and different functions. For instance, you have the dorsal cognitive circuit, CSTC circuit, which begins in the dorsolateral prefrontal cortex technically, and then moves to the dorsal aspect of the striatum, that is dorsal caudate, and then goes to thalamus, and it is relayed back. While the other circuits are sensory motor circuit, where the cortical element is supplementary motor area, and ventral cognitive circuit is the inferior frontal gyrus ventrolateral prefrontal cortex. The motivational ventral circuit is the one which has an origin from the orbitofrontal cortex. And then you have the limbic circuit, which has ventromedial prefrontal cortex and the limbic region such as amygdala that are involved in it. So these are parallel circuits, sort of partially non-overlapping in nature, and they may have specific functions in the context of the brain. These circuits are required for the normal brain functions, normal cognitive functions of the brain, and abnormalities in these circuits contribute to the neural abnormalities that are seen in OCD. So these circuits have specific functions such as, for example, sensory motor circuit might be involved in the development of habits because they might be important in the formation of habits through stimulus-based responses, while dorsal cognitive circuit might be important in some of the executive functions like working memory, planning. Ventral cognitive circuit might be important in response inhibition. Motivational circuit is important in stimulus outcome based motivational behavior, while the frontal limbic circuit is essential for some of the anxiety mediation in OCD, as well as fear extinction, which is one of the important abnormalities that is seen with obsessive compulsive disorder. So this picture sort of gives us an idea regarding the basic abnormalities that one can imagine in the context of OCD. Now, when you think about neuromodulatory approaches, there are two ways of doing it. One is the non-invasive method, and the other is the invasive method. Non-invasive methods means you don't make any sort of permanent, or you don't make changes inside the brain. You don't access the brain and make a change. Rather, you would work from the outer part of the skull. So you have repetitive transcranial magnetic stimulation, or RTMS, and transcranial electrical stimulation. One of the options is transcranial direct current stimulation. And among the invasive methods, you have ablative neurosurgical procedures, and some of the novel methods like deep brain stimulation. So these are roughly the important neuromodulatory approaches that are used in OCD. Now, we saw the diagram previously about the cortical regions and subcortical regions. So one can imagine that when you're using a method wherein you need to make changes in the cortical regions, you need to identify the scalp area corresponding to each cortical region, and then either stimulate or inhibit, understand what happens to the underlying areas when you activate or inhibit a particular brain region. So there are some key targets for NIBS, non-invasive brain stimulation OCD. Let's start with the non-invasive methods first. We'll talk a bit about RTMS and then about TDCS. But before that, it's important to identify the various targets that are important in this context. The first one would be the pre-supplementary and supplementary motor area. Now, we know that in OCD, one of the really important cognitive dysfunction is in the inability of the brain to inhibit certain responses, and this is assessed using a stop signal task. So there's a key region in the brain which is important. This is one of the key regions in the brain that is essential in regulating this particular cognitive function, that is applying a brake over a particular behavior, and how a stop signal is conveyed to the motor cortex through the CSTC projections. And a dysfunction in this region can also lead to altered recruitment of other cognitive regions, such as a dorsal cognitive control system. And that in turn can lead to development of maladaptive behaviors like habits. So there is a lot of importance that has been given to this particular brain region, which is quite close to the vertex, that's quite superficial a structure, pre-supplementary motor area. One of the important functions of pre-supplementary motor area might be the error monitoring. So how a brain keeps evaluating for errors, and if there's an error that is committed in a task wherein you do something in a rapid succession, and the brain immediately produces a signal called error-related negativity. It's an electrophysiological event-related potential, which happens after an error is committed. So the amplitude of this particular wave is indicative of the the abnormality in this particular region. So it is considered that pre-supplementary motor area might be playing a key role in error-related negativity. So there's a possibility that if you modulate pre-supplementary motor area, you might be able to make changes in some of these cognitive functions, and hence clinical picture in OCD. The other region is DLPFC, dorsolateral prefrontal cortex. Now, dorsolateral prefrontal cortex, as you know, is a very important region involved in executive functions. It is linked to the adjustment of cognitive and behavioral programming, and deficits in the circuit is thought to cause increased attention or salience to obsessive thoughts. And one more important function is about how emotion regulation might be another important function of this particular region. So since it is a region which is quite superficial and, in the convexity of the brain, and it's quite an accessible region, so it lends itself as an important region for neuromodulation as well. Orbitofrontal cortex, even though it's a deeper region, slightly deeper region, and a bit inaccessible compared to the other, the previously mentioned regions, but this is one of the classical regions described in OCD. In fact, the initial circuits discussed in OCD, the initial circuit abnormality discussed in OCD it had orbitofrontal cortex as a key region, and hyperactivity of lateral orbitofrontal cortex was thought to mediate obsessions. And it is suggested that excessive activity in the direct pathway of orbitofrontal cortex to anterior cingulate cortex loop sort of traps obsessive thoughts. This is one of the hypotheses. So it's important that if it's quite plausible that when you make modifications in the activity of orbitofrontal cortex, one might be able to make changes in these symptoms as well. And finally, the other region which is gaining importance recently is the medial prefrontal cortex, because of its role in threat perception. So maladaptive ventromedial prefrontal cortex might be responsible for salience abnormalities that you see in obsessive compulsive disorder patients, because patients tend to have a significant amount of valence or salience associated with certain stimuli, contamination, or a specific kind of a OCD stimulus. And it also might be resulting in inflexible threat beliefs. So medial prefrontal cortex is gaining importance in this particular regard. So this is a summary of cortical targets and the rationale. The reason why we're talking about cortical regions is because non-invasive brain stimulation generally is about how do you modify the cortical brain regions. So DLPFC hypofunctioning resulting in executive dysfunction and emotion processing deficits, supplementary and pre-supplementary motor area, which is involved in the regulation of striatal structures with response inhibition, and in addition, reciprocal regulation of other cortical structures like ACC and DLPFC, orbitofrontal hyperactivity resulting in compulsivity, ACC's involvement in error monitoring, and medial prefrontal cortex involvement in emotion regulation and threat perception. So this is in a nutshell the important regions and its functions and how it might relate to the abnormalities that you see in OCD. So what are the various methods that are possible? The most important one, which has a greater amount of evidence in the non-invasive brain stimulation category, is transcranial magnetic stimulation. As you might know, the basic principles of magnetic stimulation, it's a brief yet a strong magnetic field that is generated by transiently passing electricity through wire endings of typically a figure-of-8 coil in some of the classical coils, and that's placed against the scalp, and the magnetic field passes through the scalp and the skull. It produces an electrical field in the brain which underlies that, and that results in depolarization of the neurons where the target, which is supposed to be targeted. And this process, when you repeat at varying frequencies, can result in differential electrical activity within the targeted brain regions. So it depends upon the frequency and how you deliver it. So generally, at low frequency, anything less than 1 hertz is considered to be low frequency. So low frequency RTMS is thought to depress the excitability of the motor cortex, whereas high frequency, generally more than 5 hertz, sometimes more than 8 hertz, it's associated with cortical excitability. While there are other protocols where you deliver the stimulation with bursts of high frequency stimulation with varying amount of interstimulus interval, and that's called a theta burst stimulation. Now, theta burst stimulation is one of the recent changes, advances in this stimulation. It brings down the time of stimulation because you finish giving the pulses in a shorter span of time. You pack it in pulses and send it across. So that's these are the ways by which TMS is delivered. Now, there are different varieties of coils that are available. There are certain coils which are suited for deeper structures because it's quite difficult and difficult to access some of the deeper structures. So it needs certain specialized coils. So deep TMS is an advancement. And this is this particular study, which was published 3 years back, probably has a lot of importance because this is a study which resulted in FDA approval for transcranial magnetic stimulation for OCD in humanitarian grounds in treatment-resistant OCD, and that happened with deep TMS study. It's a multi-site study of deep TMS over medial prefrontal cortex and anterior cingulate cortex, with a 6-week stimulation with some personalized symptom provocation. And the study found that active arm had a significant reduction in Vibox compared to sham arm at the end of 6 weeks. And they also had a follow-up at the end of 1 month. So this is an important study for you to remember in the context of TMS, the deep TMS. So when you look at, there are enough and more studies in TMS now, different kinds of stimulation, different parts of the cortex, different parts of the brain. So I'm just taking one recent network meta-analysis to highlight what the study, what the findings are. So this meta-analysis looked at various kinds of stimulation. It could be, say, bilateral high frequency DLPFC. Someone else must have tried unilateral DLPFC high frequency, or bilateral pre-SMA. So when you pool all these studies together and then try and compare, the results were interesting. So this whole meta-analysis showed that there were almost 400 participants in the active arm and close to 300 participants in the sham arm. And the overall findings from this meta-analysis shows that DLPFC and medial prefrontal cortical stimulation were efficacious compared to sham. Specific protocols that had importance was high frequency bilateral DLPFC, low frequency bilateral pre-SMA, and low frequency right DLPFC. So essentially it is DLPFC, pre-SMA, and with deep coils, it was medial prefrontal cortex. But overall, while low frequency right DLPFC was highest ranked, but it almost indicated that most of the protocols had a similar efficacy. So I'm just trying to emphasize the point that DLPFC and supplementary motor area were found to be useful in terms of stimulation with TMS, while deep TMS, the medial prefrontal cortical stimulation using deep TMS was also found to be useful, whereas the other regions did not figure in the results of this meta-analysis. The other method of stimulation, which I would like to highlight, is the transcranial direct current stimulation. This is sort of a revival of a technique. This technique was sort of refined recently, even though this has been this was available for many years previously. But this is a rather simplistic method of delivering direct current to the brain using an inexpensive, non-invasive method using minimal adverse effects. It works on the basis of anode and cathode, and where do you place the anode and cathode on the scalp. So anode, the principle is that the anode increases excitability and spontaneous neural activity, while cathode decreases excitability and spontaneous neural activity. So weak current, direct current, when you give it over a period of time, sometimes in a repeated fashion, can result in changes in the neural plasticity. And this is something which has been studied in various basic science studies. A lot of studies that involve motor evoked potential, etc. So it's a well-known fact that direct current can alter neural plasticity. So this method of giving direct current of about 1 to 2 milliamperes using bioconducting electrodes kept on the scalp can lead to polarity specific neuromodulation and adaptive changes in the neural plasticity. So this is the picture of the conventional TDCS, which is a very simple equipment, simplistic equipment, if I may put it that way, which runs on batteries and electrodes, which are conducting electrodes. And you affix the electrodes using a tape. You measure the regions of the scalp using 1020 EEG system and then apply it based on that. So TDCS has some evidence in OCD. There's emerging evidence of TDCS in OCD. There are some studies which I'm highlighting here. Some of them are open label studies, while some of them are randomized controlled studies with a sham design. As you can see, the numbers are not huge. Some studies have really small numbers, while some of the recent studies have better numbers in the randomized trial. The anode and cathode positions are important. So some of the studies have used, for example, the study that we did from Nimans. This is a study done as a part of an MD thesis. So the anode was on the pre-supplementary motor area, while the cathode was on the right supraorbital region. While there are other studies, like for example, the Batyon study the cathode was on the left orbit of frontal cortex, with the assumption that hyperactive OFC might be a culprit in the context of obsessive compulsive symptoms. So inhibiting it using cathode might be an option according to their hypothesis. There have been other studies on pre-SMA. I can give you some of the some findings from the previous experience that we've had with TDCS. So TDCS was done, this is an open label observation in a larger case series of 32 patients. And almost all the patients in this particular study had treatment resistant OCD, and they received 10 to 20 sessions of anodal pre-SMA TDCS. And there were, TDCS was found to be quite useful, and patients had at least partial response at the end of, a good proportion of them had partial response at the end of it without having any major concerns or adverse effects. While this is the randomized controlled trial result from the same group, from our group, and this was a MD protocol of Shayant Gowda. So what he did was he assessed 25 patients and randomized them to receive either true TDCS or sham TDCS, 12 and 13 in each arm. And there was an open label phase followed by there was a randomized control phase followed by an open label extension phase. Anode was on left pre-SMA and cathode was right supraorbital. This was the finding from this particular study, where true TDCS had a significant benefit compared to the sham TDCS. There were 4 responders out of 13 in true, while in sham it was just 1 of them. So that showed a benefit. And subsequently, taking lead from this particular study, we looked at an advancement of TDCS called HD TDCS, which is a method by which you increase the focality of stimulation. So what it does is that it has electrodes which sort of optimize the focality by having a central electrode of one polarity and the surrounding electrodes of opposite polarity. So what it does is it increases focality, and it results in optimal peaking of voltage under the electrode. And this requires slightly more advanced equipment. It also lends itself, as a method by which you can locate the region using neuronavigation. If you have the MRI of that particular patient, you can feed that MRI into this neuronavigation device and then identify the pre-SMA region corresponding to that particular patient. And the electrodes, as you can see, is a small electrode which increases focality. So if the central electrode is cathode, the return electrodes would be anode, and vice versa. So this is a protocol which got completed recently, and it's being evaluated. The results are being evaluated now. I have some preliminary findings from this protocol, which was a part of a PhD work. I have the clinical result for this randomized controlled trial. For again, the findings is that following 10 sessions of HDTDCS in the true group, there were 3 out of 12 who improved with at least 35% reduction in Vibox, while no one in the sham group improved after 10 sessions of HDTDCS. So this also indicated a significant benefit of HDTDCS in the context of OCD when it was given in the pre-supplementary motor area. So this is, in brief, the non-invasive brain stimulation methods that I could summarize as a part of evidence and literature. But there are a lot of challenges associated with non-invasive stimulation. One is that there is a lot of variability of response and symptom heterogeneity in OCD. Now, the degree of treatment resistance can vary, concomitant medications can play a role. There can be changes in the cortical morphology. So when you place, when you stimulate on a particular part of the scalp, you can't be exactly sure that you're stimulating a particular underlying brain region. And what is the safety and efficacy when there are comorbid conditions, etc. So these are the challenges that one can think of, while some of these can be handled by in the future using larger multi-site studies with increasing the number of samples, standardizing the sessions, addressing the sample heterogeneity, coupling with some of the biological measures like functional MRI, EEG measures, etc., and further exploration of deeper structures like medial prefrontal cortex, ACC, etc. So, and is there a role for non-invasive brain stimulation in learning, which happens as a part of cognitive behavior therapy? So there are multiple things that can be evaluated in the future using NIBS for OCD. Now I'll move to the next part of my presentation, which is the invasive methods or neurosurgical interventions for OCD. Now, one should remember that neurosurgery is indicated only in chronic severe OCD patients who are refractory to standard non-invasive interventions. And you find quite a lot of such individuals who have significantly poor quality of life and extreme degree of treatment resistance, high severity when you look at the Vibox, severe degree of avoidance, etc. So there are a lot of patients, but then when you look at the criteria, you would find that not everyone would have reached a stage when you can confidently think about neurosurgical options. When you look at the evolution of neurosurgery for OCD, you can see how it has progressed from some of the cruder methods like the prefrontal lobotomy or leucotomy in 1930s to how stereotactic lesions could be achieved in 1960s, and later deep brain stimulation came in 1999 and 2000s, and now some of the latest methods is connectome-based targeting or closed loop techniques. So these are the advancements that are happening as we speak. Now, what are the merits of the recent neurosurgical interventions compared to how things were done in the past? Now, it's important that we carefully select patients. There's a lot of importance given to how we select, how we look at the eligibility for any of these procedures. Now, it's also based on a better understanding of the neurobiology of psychiatric disorders, particularly because we know we have a better understanding of the functional neural networks that underlie some of the psychiatric conditions and in OCD as well. And the techniques, some of them recent techniques are quite accurate in terms of targeting with stereotactic procedures, the use of imaging guidance and so on. And you have options nowadays to do a surgery without having to create a burr hole, without having to do craniotomy, without ablation. So there is gamma knife method of radiosurgery, or deep brain stimulation, for example, is a reversible method of neuromodulation where you can make changes in the stimulation, you can reverse the changes in stimulation. So when we spoke about neuromodulation in using non-invasive methods of TMS and TDCS, we spoke about cortical regions. Now we're talking about neurosurgical interventions, and neurosurgical interventions are generally done in the deeper regions of the brain. And these deeper regions can be considered as hubs. You can imagine how a large bundle of fibers or large number of regions converge as fibers into smaller regions, and you can actually when you make changes in these smaller regions, the corresponding representation in the cortex, there can be changes, reciprocal changes in the circuits which are involved, where these structures are involved. Say, for example, as you can see, the anterior limb of internal capsules fiber composition is shown there. So it has fibers coming from dorsomedial prefrontal cortex, dorsolateral prefrontal cortex, anterior cingulate cortex, orbitofrontal cortex, and so on. So when you make lesions in one part of the internal capsule, what happens is that you are making changes in you're expecting widespread changes in the brain. Similar is the case with, say, subthalamic nucleus, or when you're making changes in the striatum. So each region has its own topography and functional organization. Now, what are the considerations in patient selection? So how do you select a patient for surgery? I mean, you wouldn't prescribe, or you wouldn't consider surgery for everyone who presents with OCD or everyone with severe OCD. There are clear criteria for it. I'm taking the criteria which has been given as a part of the practice guidelines of Indian Journal of in the Indian Psychiatric Society, Indian Journal of Psychiatry. So this is something which is also closely mirrors the criteria which is used in the international standards as well. So one has to have severe OCD, and the OCD needs to be chronic and unremitting, and it should cause substantial distress and impairment in functioning. There has to be an appreciable effort in treating the person, and there has to be a demonstrated failure of using the standard treatment options, like, for example, at least 2 adequate SSRI trials for 3 months each, clomipramine trial for 3 months unless the person does not tolerate clomipramine at all, at least 2 augmentation trials. One of them has to be an atypical antipsychotic, or and it can be a risperidone, aripiprazole trial, or clomipramine augmentation, memantine, ondansetron, etc. And there has to be at least documented 1 CBT trial of at least 20 exposure and response prevention sessions. It has to be a classical behavioral therapy session, or a demonstrated inability to handle the anxiety that happens because of therapy. So some patients cannot handle the anxiety because of therapy, because of because they find it quite overwhelming. So it has to be documented, but then there has to be a genuine attempt at doing cognitive behavior therapy trial. And previous treatment trials have not been abandoned prematurely due to just mild side effects, but then one has to have these options tried adequately. And the patient gives informed consent, and patient is willing to participate in pre-operative evaluation and post-operative periodic follow-up. There may be some relative contraindications like comorbid intellectual disability, when person has psychotic illness, bipolar disorder, extremely severe personality conditions, and clinically significant neurological illnesses that are unstable. So like I mentioned, the surgery involves planning. There has to be a clinical examination to confirm the diagnosis, ensure that, list out the comorbid conditions, examine the treatment history in detail, establish refractiveness, as I mentioned previously. The investigations generally involve an MRI to rule out any structural lesions of the brain, and also for surgical planning, and neuropsychological investigations, particularly a comprehensive neuropsych assessment with a focus on frontal lobe functions and frontal lobe behaviors. This is especially important because there's a possibility that person can develop neuropsychological deficits later on. So it's important to have a baseline record of neuropsych functioning. And a screening has to be done by an external committee. This is the planning that happens. This is what we did for some of the subjects who underwent surgery at NIMANS. There has to be a clearance from an independent committee. So there was a committee which is outside of the institute, comprising of a neurologist, a neurosurgeon, and a psychiatrist, and it is reviewed by the head of a panel who was a psychiatrist. So the contemporary neurosurgical procedures for OCD can be divided into two parts. One is the ablative procedures, and the other part is deep brain stimulation. So the ablative procedures, the most important ones are highlighted here: the ventral capsulotomy and anterior cingulotomy, while the others are subcordial tractotomy and limbic leucotomy, not commonly performed. I think we can focus on ventral capsulotomy and anterior cingulotomy, while deep brain stimulation has a few targets, of which the most important ones would be the ventral capsule, ventral striatum, nucleus accumbens, and the fourth one, that is subthalamic nucleus. So these are the ones which have more number of studies. I'll first briefly touch upon what is neuroablation in OCD. Neuroablation is a way in which you create a permanent lesion on a particular part of the brain. So like I mentioned, the first two are the commonest ones, the anterior capsulotomy and the cingulotomy one. So in anterior capsulotomy, there is a lesion that is made in the anterior limb of internal capsule, and that is now commonly used for OCD. Most of the newer ablative surgery, newer studies talk mostly about capsulotomy. In anterior cingulotomy, there's a bilateral lesion made in the dorsal anterior cingulate and the cingulum bundle. So when you perform a lesion and then you take an MRI, you can see a lesion, a clearly demarcated lesion in the brain region corresponding to that. Now, anterior capsulotomy was quite common initially. Some of the earlier surgeries performed were using thermocoagulation and radio frequency ablation. And currently, most of the surgeries are performed through gamma knife radiosurgery. It produces a smaller lesion in the ventral portion of internal capsule. So this is one important study which is published in JAMA Psychiatry with as a randomized controlled trial with an open label follow-up, which demonstrated the efficacy of ventral capsulotomy. I would like to share some of the experiences, local experiences, NIMANS experiences with capsulotomy. So there were 4 out of 8 patients who had capsulotomy had at least 35% reduction in Vibox, and only 1 person had developed seizures 3 months after the procedure, while there were no deficits on repeat neuropsychological testing or frontal assessment or personality in any of the subjects. So this is regarding the capsulotomy, the ablative procedure experience. Similarly, anterior cingulotomy is a procedure, as I mentioned, it's the lesion is in the anterior cingulate cortex and adjacent cingulum bundle. So there are 2 subjects. The experience is that of 2 subjects here. The first subject underwent thermocoagulation. This is an older one, the older method done many years ago. The OCD remitted after about 2 years post-surgery, and the person also had reduction in impulsivity and anger outbursts. There's mild increase in frontal lobe and temporal lobar deficits post-surgery, while the second subject for whom the surgery was done using gamma knife did not show improvement in OCD symptoms, and even though there were no adverse effects post-surgery. So this is the systematic review and meta-analysis finding of the safety and effectiveness of neuroablation in treatment-resistant OCD. And overall, when you look at the response rate with capsulotomy, you find almost 57% response rate and reduction in Vibox of 46%, and cingulotomy 49 and 24. So generally nowadays, among the ablative procedures, capsulotomy seems to be more recommended than the other treatment options. When you look at the ablative procedures, the concerns or the side effects can be divided as acute or long-term. The acute side effects could be, if one is doing open surgery, it can result in headache, CNS infection, hemorrhage, etc. While gamma knife, it's associated with brain edema in small proportion of individuals, sometimes radiation necrosis, and long-term concerns are personality changes, cognitive deficit, seizures, urinary incontinence, etc. So even though these are listed, these may not be very common when you look at the studies that have published in the literature. Coming to the last part, it's a deep brain stimulation, which is a novel method. So what is deep brain stimulation? It's a method by which electrodes are implanted in certain brain regions, in the deeper brain regions, for long-term stimulation. Now, these electrodes are later on connected to a battery or a stimulator that provides stimulation. And the stimulation is flexible, and then there are visits required to titrate the electrical parameters to optimize the efficacy and side effects. Now, there are a lot of mechanisms discussed, but however, there is no unifying answer for this particular question. But what is understood is that the deep brain stimulation might result in disruption of dysfunctional oscillations in pathological circuits, and that might be the reason for the improvement. DBS has advantages over the other ablative methods in terms of reversibility. That's the most important thing. Even if someone develops side effects, it may be reversible. Stimulation is adjustable. But when you're doing a study, the most important thing when you're doing a study is that it lends itself as a method by which you can conduct sham stimulations, because you can either switch on or switch off this particular battery and see what happens to the symptom when when the stimulation is either active or sham. The disadvantage is that it has higher cost. It may have one has to replace the batteries periodically. It requires a highly skilled interdisciplinary team with frequent monitoring. It requires a good neurosurgical unit and a psychiatry unit and a neuropsychological assessment. So the multiple things that has to happen in a concerted manner. And it requires a burr hole craniotomy for the implantation of electrodes. So it requires insertion of electrodes, which can be kept on and off, implantable pulse generator, and then programming. It's based on the acute effects and adverse effects. And the programming itself is a process. It takes some time. It might take a few months for someone to achieve the adequate level of programming. Coming to the deep brain stimulation targets, as I mentioned previously, there are a few targets which have been examined: the ventral capsule, ventral striatum, anterior limb of internal capsule, and nucleus accumbens are the key regions, and bed nucleus of stria terminalis. But the ventral capsule, ventral striatum is a very commonly used strategy. And recently, there are some studies on subthalamic nucleus, anteromedial part of subthalamic nucleus as well. So this is a cohort of 70 patients who underwent deep brain stimulation to anterior limb of internal capsule for refractory OCD, published not too long ago, just a couple of years back, which showed a mean reduction in the Y-box of 13 points and a response rate of 50%, close to 50%. So that's a really good response in treatment refractory OCD using deep brain stimulation. And this is the study which was published in New England Journal of Medicine by a French group, which used a very elegant design of crossover stimulation for subthalamic nucleus electrode, and they demonstrated significant benefit using DBS as well. So overall, when you look at the systematic review and meta-analysis, this is from a very recent article. You can see that the meta-analysis has used 34 studies, and overall it shows approximately 40 or close to 50% reduction in the Y-box scores, and at last follow-up, 66% of participants were full responders to DBS protocol, and there seems to be a really high effect size as well. So among the long-term outcome studies, there are 2 to 9 years follow-up studies across targets. One can summarize that the early improvement is generally maintained, and 50 to 60% of patients show response at follow-up. And there are no major long-term adverse events reported. And CBT may augment the effect of deep brain stimulation. There's not much experience from DBS from Nimans, but now the studies that are being done now is on the anteromedial subthalamic nucleus. There is a protocol which Dr. Shyam Sundar, my previous colleague, is conducting at the moment through a Wellcome Trust protocol. So the outcome of this some of the initial pilot studies is that 3 patients with treatment refractory OCD is that 2 of them with at least 6 months follow-up have shown full response, and 1 patient with 1 month follow-up has shown about 20% decrease in Vibox. And so this seems to be, this region seems to be a useful method. There's a protocol which is going on at the moment, looking at various aspects, various predictors, which include various biological predictors to subthalamic nucleus stimulation. So there's a protocol that has been published. It's freely accessible if someone wants to have a look at it. And the referrals are accepted at Nimans for Dr. Shyam Sundar for this particular study, if patients might be interested to be participants of this protocol. So in summary, ablative procedures in DBS have a role in very carefully selected patients with treatment refractory OCD. Now, ablative surgery is generally one of the most important regions, seems to be ventral capsule. It's irreversible, it's a one-time procedure, while DBS targets, the important targets are ventral capsule and ventral striatum and subthalamic nucleus. And it might have flexible stimulation. It needs more closer follow-up and interdisciplinary approach. And approximately 60% of individuals may improve after the procedure overall. When I say improve, it's not a magical improvement. We're talking about 50% reduction in the Vibox as improvement. This is for someone who hasn't responded to multiple treatment options in the past, so it's not really bad in that context. It's not a standalone treatment. It should be considered to as one of the treatment modalities in a comprehensive package. So it doesn't mean that when someone receives these methods, CBT, goes out of the window or something. So some of the classical options still have a role for these individuals. So this is pretty much what I had to discuss in a brief manner. I would like to acknowledge Shyam Sundar for giving me some of the recent inputs from the studies that he's done after I moved out of Nimans, and then my mentors, Dr. Reddy and Dr. Venkat, and the funding agencies which helped with my studies. I'm happy to take questions. Thank you.
Thank you very much, Dr. Janardhan. It is really a very much in-depth information about what we say modulation therapy for refractory OCD. My question, first question, before we can have other participants' question, I think that what is the role of this modulation technique practically for the private psychiatrists all over the India? Is there any machines like ECT machines? There is different machines like that available for not as a RTMS. I think RTMS and this transcranial magnet simulation for OCD has a different types of coils. So what you can say for that?
There are various equipments available. There are various devices that are available for stimulation. What is really important for us to understand is that there has to be good degree of certification for this particular equipment, some CE certification or any sort of accreditation which comes with an equipment. I think that's something which one has to keep in mind before purchasing any equipment. There are a lot of cheap devices which, it's not a very complex technology. I mean, I'm talking about TDCS. It's not a very complex technology. So it's just a matter of anode and cathode, but then it's a matter of delivering the current in a consistent fashion for a particular period of time, and to be able to monitor that. But some of the machines, the state-of-the-art machines that are used in stimulation also enable you to do certain other methods, like, for example, random noise stimulation, transcranial alternating current stimulation, etc. So there are different protocols possible using advanced techniques. But if you just want to do a very fixed TDCS as a very straightforward technique. I think though there are equipments that might be available in the market, but just that one needs to be mindful of the certification.
Okay, thank you. Yeah. Any question other? I think there are no questions in the chat box, but I think anybody wants to ask the question can raise the hand. Yeah, Dr. Rashmin Kolera wants to ask, do deep coils offer any advantage over regular coils in the utility of RTMS for OCD?
Yeah, Rashmin, yes, deep coils, because some of the classical coils, like the figure of 8 coils or the cone coil, some of them, most of the coils generally have the major disadvantage of accessibility. I mean, when you keep it over the scalp and when you want to access deeper regions, you may not be able to access the deeper regions. Like, for example, you can easily access pre-supplementary motor area, or you can access the dorsolateral prefrontal cortex, while if you were to access anterior cingulate cortex, which is much deeper and centrally placed, or the medial prefrontal cortex, which is still deeper, so then the TMS signal, the TMS pulse would not reach that particular region. So then for that, in order to facilitate that, there are some newer coils. It almost looks like a helmet. It has to be kept over the head, and it delivers the current, it delivers the magnetic field in a slightly different manner, that it reaches deeper cortical regions. So I think it's the way by which the magnetic pulse can reach deeper structures. That's the most important advantage that it has. Definitely it is different compared to the classical coils, but they are way too expensive compared to the classical coils.
So, yeah, we have another question from Jatin. Are there any evidence of long-term side effects or a downside to DBS?
Yeah. So generally, DBS is considered to be safer, but this involves a surgical procedure. So you need to have, you are accessing the brain, and then you are inserting an electrode into a deeper part of the brain. So some of it starts with the acute concerns with any neurosurgical intervention, like the infections and things like that. But then long-term concerns are not very commonly described. You might have rare concerns of cognitive deficit, seizures, etc. But then most commonly, most of the studies haven't really reported any of these side effects, because they're done in a very much more, how do I put it? They're done in a very safe manner. And these are very small electrodes placed in the deeper parts of the brain. So they have not been generally associated with long-term side effects.
Dr. Janardhan, as you mentioned, I think FDA also approved deep brain stimulation for refractory OCD, but not this direct current stimulation is approved by FDA.
No, it's not. It's deep brain, the deep TMS, the transcranial magnetic stimulation has been FDA approved a couple of years back, while the electrical stimulation is not. Direct current stimulation is not.
Okay. Yeah, one question for Sasank Sinha, that role of TACS in OCD, comparison of efficacy with transcranial direct current stimulation and TMS.
Very small studies are available, very small studies, open label. I'm not sure if there are good randomized controlled trials on transcranial alternating current. And so your second part of the question was whether can you compare it with TDCS and TMS? I mean,
yes.
With the existing studies, it may be too difficult to make a comparison.
Okay.
Yeah, but it's a promising area, because what TACS does is that it can modify the neural oscillation. So some of the newer understandings of the psychiatric disorders is based upon how there are dysfunctional neural oscillations. So when you give TACS, what happens is that it is thought to, it's hypothesized to, stabilize or revert some of these dysfunctional oscillations. So TACS might have a role in the context of OCD. There are some studies, I mean, I can recall at least 1 or 2 studies, recent studies, very small studies, which have examined that possibility.
I think, yeah, there is no more question. I think we can say thank you very much, Dr. Janardhan. Yeah, thank you very much for this. Is very much interesting topic, and we'll all learn definitely more in this subject for neuromodulation technique in OCD. Thank you very much to you and Dr. Rashmin Kolera for giving this DY Patil series of this lecture series for PG students. It's a wonderful thing, and we thank you all of them. Thank you all participants also. Thank you very much. It's a nice session.
Thank you so much. It was a great opportunity for me, and it was a privilege to talk here.
Great, thank you. The privilege is all ours, Dr. Janardhan and Dr. Parekh. It was lucid, it was to the point, and it drove home the message very effectively. So kudos to you for that. That's amazing. And yes, this is a challenging area. OCD is probably one of the most challenging disorders we have. We talk a lot about schizophrenia and bipolar and everything else, but when you see patients with OCD and the amount of distress they experience, primarily because they have adequate amount of insight and they are struggling to cope up with their day-to-day life. So anything and everything we can offer to them definitely is a big help. And these modern modalities of treatment have definitely been very, very good value addition to the treatment protocols that we have for OCD patients. And we thank you with your extensive experience and understanding of the subject and the treatment options that you discussed with us today. It definitely does add a whole new angle to the options that we can offer to our patients, thanks to our learnings from you. So thank you once again. And again, apologies for the late hour, but you've kind of hooked us on. So we'll probably keep asking you back, and we'll keep you up at nights often enough now. So thank you very much. And thank you, Dr. Parekh, for making the time in your schedule. And of course, thank you to all the participants. We had a good number of people. And we hope that you enjoyed listening to this talk as much as we enjoyed bringing it to you. And we promise to continue to bring such exciting topics with good speakers such as Dr. Janardhan today. And of course, thank you, Sun Pharma, for their unflinching and continuous support to this academic venture. And I wish you all a great evening ahead. Thank you once again. And thank you, Dr. Janardhan. Thank you, Dr. Parekh. It was great to have you with us.
Yeah.
Thank you so much, Rashmin.
Thank you.
Thank you.